Are you in Paris? Or?
No.
Background photo.
Virtual tour.
It's a big photo. It's beautiful.
We are live on YouTube now. So I'll go ahead with the program. I'll just try to introduce today's faculty and the program. So friends, welcome to the Arthroscopy Study Group of India and Arthroscopy Academy webinar. And we have today's faculty is Dr. Stefano Giaffazzelli, who doesn't need any introduction. He is a very famous knee and shoulder surgeon from Bologna, Italy. He has been a past chairman of ISACOST 2019 in Mexico. And he is a wonderful surgeon over which he has got fantastic presentation onto the subject, and he has got many publications to his belt to show that ACL instability is very crucial and it can be dealt with many ways. So for today's program, we have many faculty, including Dr. Samir Sheikh and Mukesh Ladda, who are going to discuss the case, and so that we can discuss it with Dr. Stefano. And we have the moderators in the form of Dr. Panigrahi, Kalpesh Trivedi, Sanjay Trivedi, Rajkumar Amravati, Jaya Prasad, and Dr. Atik Vasdev, and the panelists in the form of Dr. Nishit Shah, Jiten Maheshwari, Vikram Maskar, Mukesh Ladda, Dadaria Raghuveer Reddy, Dr. Punraj, Dr. Arun Gupta, Vinay Pandey, Manoj Mehta, and many other people who are going to join us for this panel discussion on the ACL. So I'll request Dr. Sanjay Trivedi and Dr. Jaya Prasad to moderate today's discussion. Sanjay, can you hear me?
You are muted.
Yes, Sanjay and Dr. Jaya Prasad, you can start today's moderation. JP, can you hear me?
Yeah. Able to hear. Okay. So good evening, friends. It is a great pleasure to invite Stephanie for this academic program. So first talk is on the current concepts in ACL reconstruction.
Yes.
Stephanie, please share your...
Share your screen. Okay. Okay.
Yeah, we are live on YouTube. You can just share your screen.
Good.
Yeah. Just make it PPT format.
Okay, like that. It's
yeah.
Okay.
Okay, wonderful. Okay. You can go ahead.
So thank you very much for inviting me. I've been asked to speak about ACL reconstruction, anatomy, biomechanics, and ACL reconstruction, and that's it. So I construct a sort of presentation that maybe is a little bit long, but I think it can address and try to explain how I feel about our ACL reconstruction. So the ACL reconstruction, this is what I will follow on my presentation. So I will follow anatomy, biomechanics, epidemiology, mechanism of injury, surgical technique, and complication. So this is a very beautiful images that is on 3D, and I built with Pau Golano in Barcelona. And in fact, the ACL is very strange ligaments, and in fact is very difficult, and there are many aspects that probably, even if it's the more wide study, the more ligament study in the human body, is probably still we need to do something and to learn more something about these ligaments. And in fact, the ACL reconstruction is a small ligament. You see, is 3 centimeter, and in his square is probably less than 1 centimeter of lengthening, and probably is I don't know why it's so difficult to reproduce this type of ligaments. And these are beautiful images that I built, and we did the micro CT images of a ligament. So we harvest these ligaments from patients that we did a cadaver study. And in fact, you see how it is, these ligaments. And you will build that if you can with this special program that we have in our institute, that you can see how it goes and how it becomes two bundles and how this bundle can build together this ACL, and how especially the insertion, especially on the tibia and on the femur, are really different respect to the mid part of these ligaments. So it's very difficult to reproduce for this reason. And this is an old study that I did probably in 93, 94, I forgot this. And this is the ultrastructure of these ACL ligaments. And this is found that is a bimodal or trimodal distribution of connective tissue and connective fibers that have three different types of ligaments, connective tissue. So it's about 50 nanometer, 80 nanometer, and 180 nanometer. But mostly it's really important to find in this area some elastic or oxytalan fibers. That means that this is a very developed structure in our human body. That means it's very high level of evolution of these ligaments. It's not like an Achilles tendon. It's much more different. And in fact, you see in a 20 years old guy, you found a trimodal distribution of fiber diameter that along the age of this patient, they become smaller. And in fact, there is a distribution of these connective tissues that become smaller along with the age of this patient. So you see that there is a very different situation between age. And in fact, the connective type tissue that can be found is probably many, and we have different fiber diameter. That means that you have a different function. So there are function of the mechanical behavior of this ligament is totally different from another. And there are areas that maybe reproduce or resist some stress on certain direction, and other fibers that maybe resist in a different situation and in a different direction. And this is the structural properties of this ACL. And in fact, in the young, the stiffness is more high, and the ultimate loads is very high, especially if you do in anatomical orientation of these ligaments, is very high, the strength of this ACL. And the modulus, that means the elasticity of this ligament, is totally different from other ligaments. You see the MCL, for example, is more stiff, and the ACL has an elastic modulus that is different from medial and lateral part, and is much more elastic than the patella tendon, for example, that we use sometimes for replacing these ligaments. So we need to take into account also this information that are really biomechanical information, but it's really important when you are building an idea to reconstruct these ligaments. And this is a computer dissection that I did several years ago. And in fact, these are the two ligaments that I digitized in a cadaver patient. And in fact, this is what I did. So I do the kinematic, and I digitize all the anatomy of this knee, including the ligaments, and then I build how it works and how it is oriented, the ligaments and all the ligaments and all the structure around the knee while you are bending or while you rotation your knee. And this is really giving you a lot of information, and that's why this is a very old study that I did in 94, 95. And this it means that this system, this ligament is isotropic. So it can resist, related to this, how it is constructed, this ligament is an isotropic system. That means that it can resist the stress that arriving from all the direction. So it's very unique, these ligaments. And also ligament is a viscoelastic material. And in fact, it has a time and distance dependent stress strain behavior. And this interaction between molecular and structural components of the ligaments make these ligaments very unique, as I say. And it's difficult, very difficult to reproduce and to have a graft that has a similar strength, similar behavior, and similar elasticity is very difficult. And in fact, also the relevance when you're thinking about the viscoelastic properties of these ligaments, you have to take in consideration when you think about ACL graft initial elongation, what type of tension we should put at the graft at time zero, if we need to preconditioning our graft, and what happens to the ligament during joint motion, and how even the positioning of our ligaments is important to trying to reproduce as much as we can the normal behavior of these ligaments. And this is what we found recently. This is just a recent paper that I evaluate in vivo, because my idea is I'm not only doing in vitro tests, but I'm more trying to have my idea is to have more information about in vivo activities or in vivo patient, because this is the real life. And in fact, what we found in this with RSA method, with in patients that has ACL rupture, and when you have an ACL rupture, this is a very recent study that we published, we have an abnormal tibial medialization, and also you have increased varus angle of the tibia when you have an ACL deficiency. And what we found also is that this is not restored when you do an ACL reconstruction. So this medialization that it happens immediately when you have the ACL rupture, and this varus that it happens, varus angulation that the tibia has after ACL rupture, we never restore when we do an ACL reconstruction. And this is very important to know. And I think this we need to take in consideration in the future for our reconstruction. Also, about the epidemiology in the general population. So obviously we have more male than female in all around the world, but you can see that there is an increasing of age. So that means that the more percentage of age is between 20 and 30 years of age, but also there is an increasing ACL rupture even in the younger population below 20 years. And there is an increasing also between 30 and 39. So there is something that can happen at every age, but obviously has more impact in a younger population. And especially about sports, we have, this is the UEFA study that showed that the percentage of injury for 1,000 hours of play is 0.059. What we found in Italian Serie A is about a little bit more, but very low. And you see that most of the time is happening in championship match, but 40% is in training. And so definitely it can happen every time. And so it's difficult to reproduce. And also is more important, we have done some study about ACL injury mechanism. Mostly what we found is this injury, it happens in non-contact injury. 85% of these patients have an injury in non-contact. So not, and normally it happens when they do defensive action and pressing, and maybe they are around or they are narrowing to some other people, other player, but they are doing alone. And normally there is axial load, internal rotation, valgus opening, and quadricep contraction that give the stress in ACL and rupture the ACL. So this is how we concentrate our study on mechanism of injury. But now there is still not consensus in literature. And what is the most injury pattern for this ACL ligament is extension versus flexion, valgus collapse versus axial load, internal rotation versus external rotation, and also the anterior tibial translation. And definitely it's very difficult to understand from the literature. And we agree mostly with Koga, this study by Koga, that we found that to have an ACL rupture and the mechanism that it happens during the ACL rupture is very difficult to understand. But definitely for us, it should be mostly, first of all, an internal rotation that caused probably the ACL rupture. And after this, it happens an external rotation and subluxation of the ACL of the knee, especially of the femur, that goes behind. And then there is when they return to a normal slight flexion, and when they return back, there is a reduction. So this happens, and this is not a simple ligament injury, but it's really a tibial subluxation and bone contusion that can cause meniscal injury. And this is what we found when you analyze the bone bruise, that it happens when you have an ACL rupture, but probably this is after the ACL rupture that happens, this type of injury, because this is really difficult, and this is made by RSA. And in fact, you normally, in the normal squat that it happens, if you try to analyze how they can go back to make a sovereign position of this area of bone bruise is impossible. So this means that to have this area of bone bruise, it has been happening a sort of subluxation that we found in our video analysis that we did. So this is the mechanism that we are thinking that is cause of this bone bruise that we found in ACL rupture. And the more the bone bruise it is, probably the more luxation has been big, and probably the laxity is much more in this type of patient. So ACL injury treatment choice. So what we think we should think about conservative or surgical treatment. So this is a very old study by Fink that we found that the operative people have higher rating on AKDC, they are higher level in sport participating, and they quote their knee better than the non-operative knee. But obviously these patients, at least in 206, and probably this is a very old technique, they have the similar risk of osteoarthrosis. But, and the non-operative patients that osteoarthritic changes that were mostly related to the activity. So if the patient that has been non-operated, he can return to play or can continue to do some sports, they will have much more OA than the patient that they don't do nothing. So if you have to do a non-operative choice, you should really accommodate your activity according to this fact that if you do much more sport, you will have come out with much higher OA after maybe 10 years. And in fact, there is limited space for me for non-surgical treatment, especially in pivoting athletes. In fact, 2 out of 140 that they have a total rupture, and 15 out of 17 have a partial rupture with UEFA, and they have been treated non-surgical. But this is very very small group of patients that maybe they are copers, let's say, the 2 out of 140. So only 2 people out of 140 they were able to play without having ACL, and only 15 out of 17 of partial rupture. But the partial rupture, we know, sometimes if they have a good muscle control, they can be non-operated in this type of lesion. But it's not really the case for pivoting sports and pivoting athletes, where normally this choice is to do a surgical treatment. And in fact, this is a 2020 ACL study group elite surgeon. And in fact, the non-operative treatment for ACL injury in high-level athletes is 90% of the surgeon, they prefer to do a surgical approach instead of have a conservative approach. And the surgical treatment, the aims of our ACL reconstruction should be to obtain a stable knee, to reduce the laxity, to reestablish sport performance, avoid a second injury, and maintain in the long term the knee healthy and to avoid maybe OA. So this should be the goal of our reconstruction. And in fact, ACL, the surgical treatment, there is actually still for me, there is no gold standard for ACL reconstruction. In fact, you can use different graft, you can use different graft diameter, you can position your femoral tunnel in a different way, in a different placement, even do not do the femoral tunnel, and even you can choose different fixation method. And sometimes you should be the case to do some associated procedure together with the ACL reconstruction. And in fact, there is a lot of literature about this topic. So the timing also is another issue. In fact, this is a meta-analysis, a recently meta-analysis that we did. And in fact, if you do the anterior cruciate ligament reconstruction within 3 weeks, you have not increasing stiffness and complication compared with delayed reconstruction. So definitely, it should be better to do the reconstruction the earliest possible. I would say the day after the ACL rupture, if it's possible, in the elite athletes would be the best, to really restore as much as possible and the early time as possible the normal situation of kinematic and of not to avoid some injury that can happen if you leave the patient with some instability for a certain amount of time. So for me, the as early as possible is the best. And what are the characteristics that should have an ideal graft? It should be readily available. It should be 100% safe. Should have mechanical properties equal to ACL and PCL, minimal early morbidity, to have a secure early fixation, no long-term morbidity, 100% graft incorporation, and no deterioration over time, and to maintain excellent clinical results over 20 years. So this is really still impossible to have a graft like that, but we try to do our best to improve our ACL reconstruction. And this is a survey that we did in our Italian Knee Society. And in fact, so far, still the graft more used is hamstring in males and 91 in females. And 44% hamstring in pro athletes, where in this case, some people use bone tendon bone. And the hamstring critical aspect is that in some type of patient, they have a higher failure rate, and they have donor side morbidity of flexor muscle that could have some weakening of medial side, and they can have a small diameter that sometimes for some surgeon can be maybe a sort of weakness of this construction. But the BTB versus hamstring in footballer, it has not been shown to really be statistically significant better results. And in fact, hamstring have 11% of re-rupture while versus 8% of BTB. And in this Swedish article, no re-rupture risk between BTB and hamstring. So it's really the same. And I think it's not a matter of graft, but it's a matter of technique and where we put our graft and how we build our graft. And this is important. And in fact, the BTB, the main critical aspect is that they have donor side morbidity and they can have complication of anterior knee pain and kneeling pain and stiffness and some patellar fracture, especially in sports. And they are more definitely arthritic changes in the long-term follow-up. And the HTA, the hamstring main critical aspect is the flexor muscle that if you train very well, this can be solved. So these are the two grafts that mostly are used so far. and not indicated in kneeling patients, BTB, and is not indicated in sprinting athletes. Maybe if he's a runner, sprinting runner, is better not to use the hamstring. There is a new graft that is not new, but some surgeons use the quadriceps tendon that is a performance as a BTB, but without BTB complication. Is a shift of paradigm in graft choice, but definitely there are more surgeons that now they wire into this graft, but and I have done for some one of these ligaments, but I was afraid of this Linde paper that came out just last year, where the use of quadriceps tendon, at least in Danish registry, at 5 years follow-up, maybe because corrected for learning curve, they have 2 times risk of failure respect to the other graft. So we have to take in consideration that when you go in a different way respect to the old one, you have to consider that you have to have a learning curve, and maybe you have to very know what you are doing, because sometimes it can be dangerous to change your graft. And in fact, this is again the trend of ACL study group. The hamstring autograft is still the best. There are some surgeons that use still BTB autograft, and there is a quad of autograft with bone or without bone that has a sort of 20% of graft choice in elite of our elite ACL surgeon. So definitely there is a space. These are the 3 grafts that are mostly used for doing our ACL reconstruction. And I think ACL reconstruction should restore ACL kinematic. And this is one of my study of I did in 2000, where I digitized all the fibers of all the anteromedial and posterolateral ACL, and we evaluate the length, the distance between the 2 insertions, the 2 points at the insertion area, and the ligament itself. And it came out that is this. And we built a sort of mathematical model of this ACL ligament according to the fibers that I digitized completely along the ACL. And in fact, if you consider the linear fibers, so that means the distance between the 2 insertions, the length is 1. If you consider the real length of the fibers is much longer. And in fact, it works if you do a flexion extension, considering only the linear fibers, so that means the distance between the 2 insertions. If you do a bending, every time you bend the knee, you broke your fibers. So that means that the linear fibers is not a sense. So the isometric point is no sense, because the ACL is really curved, and there is a fiber recruitment that it happens every time you bend the knee. You have more fibers that become tight and become slack according to the area that we belong. And this is really important to know. And when you build our ACL, we need to consider that we cannot think about an isometric point, because it's really a false, is a fake. And this is happened. This is a real situation of an ACL. It's like that. And these fibers can become tight according to the degree of flexion that they can reach. And it's really difficult for me, and I think we still have not done this in our reconstruction. So we are not able to build this type of slack and tight part of ligaments according to the degree of flexion. And this is what we probably should work much more on this part, and maybe to reproduce more the insertion of this ACL, to really try to reproduce or to mimic as much as we can the kinematic behavior of these ligaments. And again, the pivot shift is an important test that is the only one that correlates with functional outcome of patient satisfaction. And definitely is difficult to perform and it's difficult to quantify. In our lab, we build this device that is allowed to give you the data and to quantify this test. And you see, you can build the curve of a ACL rupture, and you can know how much is the pivot shift test laxity of any ACL that you did. And this it really can help you to really reproduce and try to understand how much is the recovery of laxity at the end of the surgery. And I validate this device by using of navigation. That again, I'm still using navigation for my test and for my study, because in OR, the navigation is the more precise method and the gold standard to do some data and to achieve some data about our reconstruction. And in this case, I built this validation way for the new device. And I think the in vivo knee quantitative kinematic by used during our navigation and by navigation in our ACL reconstruction should be the goal. And there are very few navigation available for doing the ACL reconstruction. And why I use CAS in ACL reconstruction? Not really to drill my hole. I know where I have to put my ACL, but really to make a laxity measurement and to really to have a kinematic under different clinical stress and to evaluate and try to improve our surgery. And this is why I do some navigation during my ACL reconstruction, and I'm still doing sometimes. And in fact, the goal should try to reproduce these two bundles of ACL, and these trying to restore as much as we can the insertion, the anatomy, as safe ready, but we are still far away from this. And there was in 2000, there was the idea of double bundle that in the lab it showed to have better performance because you put more graft inside and to have a more reproduction of in situ force of anteromedial and PL. But really, if you look in vitro and in vivo test, there is no difference, or sometimes superior. Some data show superior laxity about double bundle, but clinically speaking, there is no difference between, still no difference between these two reconstructions. And in fact, this study that I did in 2012 showed that if you compare the double bundle to a single bundle plus lateral plasty, indeed, what we found is that the laxity reduction is better controlled at 90 degrees with the lateral plasty than with the double bundle. And that's why I think we should think that the two possible solutions, or we try to go more anatomic as possible to do a double bundle, but increasing the risk of having complication, or you can work on the peripheral plasty. And this is what we did. And this is a long story because we started doing a lateral plasty in our hospital in '93. So it's already more than 27 years of reconstruction. And this is a trend that are normally performed in our ACL group. And in fact, the single bundle is done in 50% and only double bundle in 10% of the cases. And so it's really most of the time is 90% is a single bundle. But the role of extraarticular plasty, you see that there are patients now, even in the ACL study group, many surgeons, they think that there is a role for an extraarticular augmentation during primary ACL reconstruction, and only less than 20% of the surgeons are able to do ACL without adding something to the lateral plasty. And this is our technique that I show Last year I was in Mumbai with Roshan, and in fact I did one of these reconstruction. That is a little bit particular because he has leave the tendon insertion attached to the tibia, and we saw later that this is a sort of improving our reconstruction. There is no femoral tunnel because we go over the top, and we arrive to the place where there is the insertion of the really extra-articular tenodesis isometric point by Krakow in '86 that show that this point is the more isometric one. So you can go with this Kelly, you bring down the suture loop, and then you bring the suture loop on the tibia, and then you pull up your tendon, and the ligament is done. So it's really a very cheap technique, a very simple technique. The only thing that the Americans don't like is that because inside the ACL is not so big, but the ACL at the middle of this length is not so big as normally is. And definitely we add a lateral plasty to this procedure using the same graft that we use for ACL. And this is really improving our possibility because in this case, you don't have any lesion of any tightening of the lateral iliotibial band that can be a sort of increasing the stress on the patella and on the lateral side of the knee. And in this case, you just use a graft that is a part of the normal situation. And we evaluate our technique. We have a prospective study that evaluates the same group of patients at 3, 5, 10, and 24 years follow-up. So it's really well been studied, this technique. And we have also done recently a sort of safety of our the top lateral plasty. We evaluate 259 2,500 cases, and to see the case of readmission, we have only 227% of readmission, and most of the cases were deep infection, very low, less than 2%, and some sort of hematoma in relation to the use of heparin that we have to use in our still in Italy. And this, you see superficial infection and only 0.50% of deep infection. So definitely is a very safe procedure. And this is a comparison that we did in 2006, comparing our technique with the patella tendon and with the quadruped hamstring. And we found that there is no difference between these three techniques, and better stability respect to quadruped hamstring, and less average side morbidity with respect to patella tendon. And they have higher number of excellent paper, excellent patient respect to the other two. So definitely there is a several, at least is similar to patella tendon, but for me, a little bit bigger. And this, as I told you, what we found, this is a paper that came out just this year. And in fact, we evaluate the graft maturation, evaluating the MRI, intense MRI, 4 months and 18 months. And you can see, if you leave the attached the tendon, you have a better tunnel integration, you have improved clinical score and correlation with signal. So definitely, to leave attached the tendon, you have a sort of vital graft that can improve the reconditioning and the ligamentization process of this graft. And definitely this is really important. And this is another paper that has been just recently accepted to ASSM, where we evaluated the group of 244 patients that has at least 10 years follow-up. And there is a 30% of overall reoperation. So there are patients that has been done in 2007, 2008. And we have only 3% of revision and 4% of meniscectomy. And you can see the higher percentage is staple removal, that sometimes they can have problem because it can be a little bit, especially if the patient are thin and they have a big fascia lata, they can have some pain in the area of the staple that needs some reoperation. But this, you can see that there is 73% of excellent patient, 15% of good, and the worst sport and quality of life is in patients that are female and the patients that have outer bridge more than grade 2 in some area of this joint. So definitely is a very, at 10 years follow-up is definitely is a very big success. And this is also the sport activity, and most of the patients at 10 years are involved in recreational soccer, and most of the time the sport has been abandoned to personal reason in 2 out of 3. So definitely there is a sort of very good results of this reconstruction. And this is, as I told you, the 24 years follow-up, where we found 86% of excellent or good results, and patients that are able to return to sport, 41% at 24 years follow-up. And what is important is that there is no any OA if they don't do a meniscectomy. So the OA is related, the medial OA is only in patients that have medial meniscectomy, and there has been no lateral OA or patellofemoral OA in relation to the lateral plasty that we perform in these cases. So, and this is really important to know and important to underline in this type of patient. And regarding the outcome, what we found, this is what we return to sport. If you go in an early phase, most of the literature can show that there is a very return to sport very high. But if you start going to a longer follow-up, then the maintenance of return to sport is a very going low down, and it become very low at 7 years, so 36% in this group of patients that probably is the moon group. And this is really difficult to know. And I think because in this patient, it increasing the importance of menisci, as I say, and this is a paper that we published last year. And we have also a podcast for this study that we did. And in fact, we found that the partial meniscectomy is increased the residual laxity after ACL reconstruction of 2 millimeters. And if you have a middle meniscectomy in this type of patient, you have a very increasing of laxity, and this could be the reason why the patient go back to play, but then they are not able to play anymore because the absence of the meniscus can increase the lesion on cartilage and can give some pain to this type of patient. And also, you see, this is another study made by Williams, where we found that the medial meniscectomy and lateral meniscectomy has a longer time to recover, and they have a higher incidence of adverse events. So they have 69% of patients that have some sort of pain, and repeat arthroscopy in 7%. So this means that the absence of the meniscus in this type of player is really a big mess, and it can be really deteriorating the results. And also this is another group of patients where we can show that it's not ACL that reduce the career of this type of group of patients that are NFL or NBA, but it's the meniscectomy that can shorten the career of this patient by 1.6, and meniscus plus ACL 2.4 shorter career in this type of patient. So this is to underline the importance that we found now more and more, and we pay much more attention to the menisci, because we really think that this is the key issue that we need to understand if you want to have our technique that maintain the results over time and they don't give OA to this patient. And this is another result that we did. In fact, we found that the second ACL injury is up to 25% in Serie A, and they are re-rupture or contralateral injuries. So it's really in a big percentage, and there is up to 110% of ACL re-rupture in 5 years, and a 20-fold risk of career shortening. And so this is definitely a very big problem, and we need to understand how we can prevent this and to prevent the contralateral injury. That is even the re-rupture, because it's really an issue in this type of patient, and especially in the younger population is even more. And in fact, we evaluate this in 240 patients under 18, and we have confirmed the 2-time risk of contralateral ACL, so 80.6 to versus 16.8, and 55% of survival rate in active patients. So you can see how the survival in this young population is very low, especially if they return to play in a very short time. So again, we need to really solve the problem of a return to sport in this young population, because this is a big issue, because to have a re-injury of the same knee or the contralateral knee in a young patient below 18, it can become really a big mess for their knee and for their life all. So to take home message for me, ACL reconstruction represents the most reliable approach for an ACL injury. So we have tried to respect the patient-specific anatomy in ACL reconstruction. So we have to try to customize as much as we can our surgery according to the degree of lesion, but also to the request of the patient, because it depends if he's an athlete or if he's a normal life people. And ACL reconstruction must be able to fully restore the native knee biomechanics. And to do so, we need maybe to do sometimes some different gests in our ACL reconstruction, and maybe think about or reproducing the anatomy as much as we can, or to go to the periphery. And we need to show the importance of meniscectomy, and contralateral injury is really the main complication and risk factor to develop OA. And so I have now, in the last maybe 5 years, I have very much increased my meniscus suturing and meniscus replacement in this type of patient, because I think only in this way you can save the life of this knee. Thank you very much for your attention, and I invite you to publish in my paper, my journal, that I am the editor-in-chief. Thank you. Any questions?
Thank you, Stefano. I think we are open for discussion now, and
Stefano,
thank you very much. Yes.
Stefano, very comprehensive overview of your long experience about the ACL reconstruction. And again, very much impressed to see your technique, which you showed in academy when you were in India. Yeah. If you start from the beginning, you said that you recommend early intervention in the ACL injury. Do you reserve this approach for athletes, or anybody who comes to you with the ACL rupture today, you are ready to operate him irrespective of his bone contusion, swelling, spasm, whatever?
So in the athletes, elite athletes, I would say to go as soon as we can.
Agree.
So first day after the ACL injury should be the best, even the night before, after the injury. But for the normal population that I saw in my normal office, sometimes I saw patients that arrive maybe 1 week after the rupture, that they have a big swelling and they have a little bit of decrease of range of motion. And in this case, I try to wait until the swelling is reduced and the range of motion is reaching at least 0, 120. And if they reach this type of range of motion, then I can do the surgery. But I can wait maybe 2-3 weeks to wait this swelling and the range of motion recovery. This is what I would like to do in the normal population.
Yes.
Doc, what is your approach towards the proximal ACL fiber ruptures and ACL repair with augmentation with an internal splint for these?
Yes, I think there is a lot of study about this, about the study made by, I forget the name, the lady from Boston. I forgot her name, but is very famous that has done the sort of study about ACL repair with the sort of
Martha Murray.
Martha Murray, exactly. And I think I would like to do this type of cases only in very young population and in a very acute cases. Because for me, if you wait 1 week, this will not do the same as you know, if you do in a very acute setting and in a very where there is a really detach from the femoral side, and then you can put some suture and you can pull up the ACL on the femoral side, and this could work. But I think I'm not so confident. And there was a study, there was a technique that has been done by Palmer in the 60s, and why they didn't apply or they didn't work. I think there is a sort of very small area where you can apply this type of technique, and this could be the case. So very young, 11, 20, 15 years old,
Yeah.
the very maybe knee that has really a detachment from the femur, and then you can try.
Stefano, I have a question related to the biomechanical study which you have published, especially the multiple fibers, the anterior, the central, the lateral, the posterior. All fibers have a different length in different flexion. So if we have to reconstruct one fiber, which fiber you choose? The anterior, the lateral, the posterior, or the
I would say the central in this mind.
Central one.
Because for me, the central on the femur and on the tibia could probably reproduce so far as much as we can the behavior of the ligaments, because it's very difficult unless you have a new reproduction of the digital that they have on the tibial insertion, because in the tibial insertion it's like a chicken foot, and it's really a sort of really thinking that we never reproduce with our tunnel.
Because Stefano, why I'm asking this question? Because a few years back we had a boom about double bundle reconstruction. And
Yes.
there are a few guys in Japan and Korea, as well as in South America and America, who are doing triple bundle ACL reconstruction.
A triple, yes.
Triple bundle. So
yes.
Are you proposing that there are 4 bundles now, anterior, posterior, central, and lateral?
No, I'm thinking, and I work on this, and I can tell you that I make a sort of patent on something that I'm trying to reproduce the ACL insertion on the tibia.
But we never found the right position, the right tension into the bundle so as to mimic the normal anatomy of the ACL.
Exactly. It should be normal, trying to reproduce with the graft the ACL insertion on the tibia. This is my goal for the future.
Okay.
So,
Stefano, it was shown in your lecture that in Danish registry, the failure rate of the quadriceps tendon graft was almost double. So what could be the reason for that? Can you throw some light on that.
Because I have the phone here that doesn't work. Can you repeat the
Yeah, in Danish registry, it was shown in the lecture that in Danish registry, the failure rate for the quadriceps tendon graft was almost
Yes.
double. So what
Yes.
could be the reason for that?
I think this is just a paper from Danish group, so a very small literature, because even if it's a Danish registry with maybe a lot of patient done, but in this patient at 5 years follow-up, they have a double number of re-rupture. So it's probably related to something about the fixation, because this tendon has one part that has not bone, and maybe it could be a weakness of the insertion and the fixation of the part that has no bone, or it depends, I don't know, maybe we are not so very good in understanding what is the graft, and maybe we should maybe study more how it is the quadriceps, because I think it's different from patella tendon, and maybe it has been built in a different way, and that's why it could be a cause that maybe you have a sort of biological failure more than on the patella tendon. This is my reason. But I have
Vikram,
done
yeah,
three or
Vikram, you wanted to ask
Dr.
a question.
Zafignini, wonderful talk. And I had two parts to my question. The first part is, how do you identify a COPA? That is, are there any specific tests we can do on the patient? If yes, how many weeks or how many days after an ACL injury do we do these? The second part of my question is, when you identify a COPA, how does a COPA actually cope with the lack of a ligament? Is it neuromuscular control, or is it something else with which they cope?
I start with the first, with the second one. If you have a copper, the functioning is able to work without ACL because of neurofunctional moment. And also he has to do a lot of neuromuscular training, more than training itself. So it's really a sort of coordination and acceleration, and to understanding when one is copper or not, I think you need to have a device like the Kira that I show you about evaluating and quantify how lax is this patient, and maybe identifying that maybe it's not really a complete rupture, but it's a partial rupture. And most of the time in the partial rupture that they have not a big pivot, you could try to do a sort of training, neuromuscular training, and see after 2 months if they work. If they are able to do some sports, some cutting exercise, then you can try. But again, this is an area where we should maybe work on research and to do some on-field rehabilitation and on-field test with some device that measure what you are doing and what they are doing, and comparing the knee, the healthy knee, with the contralateral leg, not knee, leg, because you have to evaluate from the core to the foot. And this is what I'm doing right now.
Abhinav?
Good evening, sir. An excellent talk, Professor. It was really a privilege to be a part of your surgery last year in Mumbai.
Yes, I remember you.
Thank you, sir.
You're a very, very good guy.
Thank you, sir. Thank you, sir. Sir, I had a question that you had a survey that told around 80% of the people have got a tendency to do the ALL reconstruction. So what would be do you do ALL reconstructions in all your primary ACLs, or would it be a specific indication like an explosive pivot or something like that?
For me, in my technique, the lateral plasty is a part of the reconstruction. So for me, I normally do almost in all my patients, because for me, it's part of our ACL reconstruction. And since I have demonstrated that I have no lateral restraint or hyper restraint of the lateral part of the knee related to this procedure, and I have no over constraint of the lateral side and on the patella, why not? If increasing my results and decreasing my percentage of complication. why I have not to do? So obviously, if you have a guy that does his quadruplet hamstring, I would say that I would do this type of reconstruction when they have a higher pivot, like let's say grade 2 or grade 3 pivot, and the patient maybe hyperlaxity, or they have some sort of anatomical factors like the slope, that they have a bigger slope, then you should think about doing this procedure.
Gaurav, you wanted to ask?
Yes?
I'll just unmute myself. Dr. Stefano, thank you so much. And you've got a huge experience in these. My question is somewhat connected to what Dr. Kalpesh Trivedi was asking. It was an eye-opener to know about the quads tendon, because we have been using it for revision surgeries of late. So first thing is it better for a quads tendon to be used with the bone plug from the patella or just the free quads tendon? Which do you think is a better idea? And second, I've been using it for revisions. Should we keep away from it? I mean, the Norwegian registry was quite of an eye-opener.
No, I think if somebody is feeling well in using this graft, I'm not against but quadriceps tendon. Actually, in fact, I have used me too for some revision cases. And when I normally use this graft, I normally use with the bone plug on the patella. So for me, without any bone plug, it's become too short for me, and I don't think is useful. And if you can remove a graft on the bone graft on the patella, that is not really a big issue. And you just have in the upper part that where the patella is bigger, and is not a big issue. And for me, it's just a matter of technique. I think it's really depending, the result that has been shown is becoming related to the technique more than on the graft. In fact, all the literature says that the graft is not important, it's how you do your technique.
So, Stefano, your graft size in your technique on an average is what, 7 or 8?
7 to 8, yes.
7 to 8 most of the time.
Yes, yes.
Stefan,
Because it's how is the ACL, the normal ACL? Why you have to put 10 millimeter of graft and then you build and you fill all the notch, and this become a cyclop way of having ACL.
So your technique is contradictory to the footprint reconstruction in all the footprint area of ACL, which is propagated by many researchers in recent times.
No, I say it's a different way of thinking, because also to do on the femur, to go over the top, you are sure to be posterior, and this is what you should do most. And if you look the first images of my presentation, and you look the image from posterior of the normal ACL, is really going around the condyle, and it's you should reproduce, and you should fix the graft there to have a real insertion of your ACL. So
the exact location of your staples. Location of your staples.
The location of my staples are really when the condyle finish, and you finish the posterior condyle and you start the shaft. There is where you should put your staple.
Stefano, if
can I ask?
Yeah, Dr. Anta.
Hi.
You're driving.
Buongiorno.
Buongiorno. How are you?
Professore. How are you?
Good.
Nice lecture. Thank you for telling us so much of the morphology, stiffness, and modulus of the ACL and the various fibers. I was wondering, when you talk so much about the morphology, and I hear that you make 7 or 8 mm graft. So does it correspond to your philosophy? One, and second, I hear you do extra-articular tenodesis.
Yes.
In primary. And what do you do when you have to do revision?
Allora, morphology is really important because if you look at the size of the ligaments, is really in the mid part is really 7 to 8 millimeter strength in the mid portion. So it's not so big, the ACL, and we need to reproduce the insertion, but still we are not doing this properly for me. And this is one of the issues that we should improve in our research. Regarding the graft, the ACL, I do the lateral plasty in all my procedure because I think is improving my results. And you asked me, what was the last question?
In revision. In revision.
In revision, I normally, if I have to revise a patella tendon, I use my technique as normally as a normal ACL because most of the time I can do it. And if I have to revise a hamstring, or I use a patella tendon, or I use quadriceps, or I use allograft Achilles tendon doing my technique, but with a long Achilles tendon.
Stefano, you had a wonderful experience about the over-the-top position reconstruction over the femoral condyle. So do you agree with the fact that the previous over-the-top reconstruction, before we landed up with this anterolateral portal and the anatomical reconstruction, where we decided to go very close to the articular cartilage, the previous over-the-top position reconstruction through transtibial technique were as good as the current technique of yours which you have shown, or it is the extra-articular lateral plasty which is playing a major role than the intra-articular ACL reconstruction of yours?
You mean that you want to know if my reconstruction is different respect to the one that was done before?
Yeah, transtibial reconstruction versus the current technique which you have just shown, over the top position reconstruction.
No, I don't do transtibial.
No, but in comparison, both are same. In transtibial, we also go over the top and we fix it on the femur. In your technique, we go over the top, don't fix it on the femur, we fix it on the lateral epicondyle.
Yes.
Yeah. So is it the lateral plasty which is working more often? So that means if I combine transtibial with lateral plasty, I will get similar result?
No, because I think the combination of my graft inside and outside is self-adjusting itself. And if you look, my graft inside is very low on the femur. So it's very low. And it's really sort of reconstructing the PL bundle of the internal graft. And then you have a lateral plasty that reduce the stress on the graft inside in the first phase. And then it protects to the rotational stress during the normal phase after 1 year.
So lateral plasty has become a procedure of choice as a primary reconstruction of ACL, part of primary reconstruction?
For me,
or
yes.
or lateral plasty is a reserve procedure now?
No, for me is a normal procedure for me to do inside and outside.
Stefano, in what position you fix in your technique ACL component of the graft, and what position you put your knee for your lateral plastic component of your graft?
So the ACL graft, I fix about 70 degrees of flexion, because if you go over the top, you have to have a tightening of the graft during extension. And if you bend a little bit the knee when you fix it, it's better. And for the lateral plasty, I normally leave the same amount of flexion and the foot in neutral rotation.
70-degree flexion for lateral plasty also.
Yes.
Stefano, you use only semi-T or semi-T gracialis both?
Both, semi-T and gracilis.
And both are single-stranded?
What?
Both are single-stranded, if I'm not wrong.
Exactly.
Till you get 8 mm graft, because even after quadrupling a semi-T, most of the time we don't get the 8 also. So we have to add.
Normally my size is 7 most of the time. In a big guy, I can have 8. I never had 9. So 8 and 7. And just when I do a graft like in kids, because this technique it can be just putting the tunnel on the over the physis.
Yeah.
I can do even for kids on growing, in grow. And in this case, I normally do an X-ray to check if I have really be over the physis. And in this case, I normally do a tunnel of 6.
Okay.
So,
Have a
no,
better placement on the tibia.
Yeah.
Where does the graft heals on the femoral side, whether it is intra-articular or on the lateral tenodesis side?
What you mean?
Where does the graft heals? Intra-articular or on the lateral aspect?
The graft heals on the hole that I do in the capsule, because to go over the top, I make a sort of hole by a Kelly on the capsule, posterior capsule, and there is a scar tissue that fixes the graft. And I've shown the MRI of 24 years graft, and you saw that it was very beautiful. And in fact, the scar tissue of the capsule posteriorly and on the staple is enough to fix the graft.
Okay, I think we should move on to the next talk, Sanjay.
So,
Roshan,
Last question.
One point. Yeah, Stephen,
Roshan.
you are getting
Yes.
excellent results with your technique using 7 millimeter of graft in elite athletes also, I suppose. So inference from your study, should we consider when we have the small diameter graft, it should be protected with the extra-articular tenodesis or lateral plastic?
Yes, when you have a smaller graft, you should do a lateral tenodesis. If you don't use on routine, you should do, especially in this type of cases also.
Stefano, what is the difference between your technique and modified Macintosh, which was propagated earlier days in the 90s?
Macintosh was using lead and just was using a sort of periosteum of the patella. And it make a tunnel on it make over the top on the femur, yes. Yes, so it's a different technique in relation to the graft, because he was using a patella tendon and periosteal of the patella itself, and increasing with the graft, with the lead, Kennedy lead,
And the quadriceps.
artificial ligaments.
I think,
So,
Stefano,
yeah,
we should move
let's
on to
move
the
on to the second talk of this session. Stefano, if you could share your screen, please. This is about the additional surgery you perform along with your ACL reconstruction and its special circumstances.
I hope you enjoy.
Thoroughly.
We are enjoying you.
Okay. Okay, so thank you again. And this is ACL reconstruction and associated procedure. As you've seen, you know what we do with the ACL. And in fact, the knee is a complex joint. You have seen that you have the meniscus, the cartilage, you have the alignment, you have the ACL, and you have the anterolateral ligament, or what we should do about using or treating anterolateral and anteromedial reconstruction, perché voi non l'avete messa l'anteromedial. And in fact, I think we should do as much as we can a la carte surgery according to the patient demographic and expectation, and also to the situation. So if you have a destroyed knee, but you have a 30 years old, how you can do to give indication of a total knee. For me, the indication of a total knee, it should be more than 65. And before 65, I tried not to do a total knee, and I try to go for a conservative or biological or approach. And in fact, you have to combine maybe ACL reconstruction to osteotomy or to different type of things. And in fact, you have seen that I normally use the anterolateral ligament reconstruction when I can have some anterolateral ligament laxity, but I do the same on the medial side, even if I just finish a study that I evaluate the efficacy of ACL reconstruction in anteromedial laxity. And in fact, the result at 11 years are really the same, even if you do or if you don't do anything on the medial side. So this is really important to know. And in fact, the lateral plasty is really an issue of mostly European people. In fact, you see, before 2000, there was some Americans that still they were doing some lateral plasty. After 2000, it was mostly European that experienced the continuation of doing a lateral plasty in this type of procedure. And in fact, you cannot compare the old tenodesis that was done in the 80s and 90s. This was Marshall that was doing a lateral plasty and with rehabilitation that was much different, 3 months cast, no weight bearing, and the new not comparable to modern lateral plasty that in this case, this is my technique, but even if you use iliotibial band harvesting and then you pass below the collateral and so on, is much different than what you've seen on the top. So in fact, there is a study that shows that the addition of lateral plasty does not increase the risk of OA. And at 11 years follow-up, there is very low incidence of OA, even if you use a lateral plasty. And the greatest predictor of osteotomy, as I said before, is the meniscectomy. So that means that we need to more attention to the meniscus. And also, if you see, these are 2 studies very recently, that the addition of lateral plasty significantly reduced graft rupture and is compared with the intraarticular isolated procedure, and the long life is more for the hamstring plus lateral plasty. So that these are results that shows why most of the surgeons right now, they are, especially in Europe, we still do more lateral plasty than before. And why lateral plasty? Because you have a control rotatory instability, and it's better to control from the periphery respect to the center, and reduce the ACL graft stress that has been shown by Engebret's in the 90s. But there is not really improvement on P stability, but mostly on rotational stability. And so this is why I use the lateral plasty, and this is why I do, because internal rotation and pivoting during injury, you can have a damage of the anterolateral capsule that can be the rationale for being a combination of ACL plus lateral plasty. But at the same, now I just did yesterday an ACL rupture that has still at the end of the surgery has an MCL that was slightly opening at 30 degree, not at 0 degree, but at 30 degree, there was still a little bit of opening. And according to my results of the study that I just finished, I should have not done anything. But I know that this patient could complain about some laxity, complain about in the early phase. And so in this case, I just do a sort of a Houston procedure where I do a sort of cappotto, sort of, how is called? I did a coat overlapping of the capsule, of the posteromedial capsule, to reduce the stress on the, and to decrease the laxity of the medial side. And in fact, when I test the ligament at the end of this procedure, it was much better than before. So this is why we should be aware of adding lateral or medial plasty when they need it, and when you think that there is slackening, can be deteriorating of the results of your intraarticular ACL reconstruction. So then you can see the alignment is another important issue. And in fact, the osteotomy, the goal is to unload the affected compartment, to stabilize the joint, to increase the function, decrease the pain. And you need to protect the meniscus, as I said, and the cartilage, and delay TKA as long as possible, and don't complicate it. And maybe we should think about, I normally don't do much more cases where I can combine ACL with osteotomy. And in fact, the osteotomies create an optimal environment for subchondral and cartilage regeneration. I won 2 years ago a Minister of Health Italian that I have to still start this project, but I will do about osteotomy and the effect on osteotomy on the progression of OA, and to reduce the risk of increasing OA in this type of patient. And there is a study that's shown that osteotomy improve the GAG concentration, and so you have the medial tibia plateau after 2 years after osteotomy. So that means that this could improve the results, and there is also a partial cartilage regeneration that has been shown by Wu in arthroscopy in 2014, and in 92% of the condyle and in 70% of the tibial plateau. So that means that even acting on the alignment, it can improve even the cartilage inside the joint, and this can change and affect the results of your ACL reconstruction. And in fact, ACL osteotomy, the indication for me are double varus and triple varus. And obviously, in revision ACL, when it has been done before a meniscectomy or partial meniscectomy, and there is a malalignment, and there is an increased capsular laxity, I should think to do a revision ACL plus osteotomy. And more in re-revision ACL, you should do all in three. So you should do the re-revision, osteotomy, and even to add the MAT procedure, because when you have a meniscal deficiency, instability, malalignment, and chondropathy, you should address everything if you want to get the best results. And this is what I do. So this is ACL osteotomy plus osteotomy ACL 6-year follow-up. And you can see this was a slightly varus knee already, and he had the meniscectomy before. In this case, it probably was one of the first cases because it's probably now 20 years follow-up. But in this case, I didn't add a meniscus transplant. But in this case, done now, I would probably do 3 in 1. So then you have the menisci, and in fact, most of the time, due to the importance of the meniscus that I show in the first presentation, you have to pay much more attention to suture or to try to preserve as much as you can of the menisci and to replace it when it's gone. And so the suture, as you know, is not always possible. So the scaffold that I've used, and I will come out with some paper about scaffold, and I have done all the evaluation of my old CMI. I've done more than 200 CMI in my practice, and the ultimate goal is to prevent or delay the cartilage degeneration. And the allograft and scaffold have different indication. So the meniscus scaffold is younger patient, normal limb alignment or correction of alignment, and you have partial meniscus defect or acute lesion that is irreparable, and this patient has less pain, more function, and prevent degeneration, and I can show you some case. And the IMREF has shown the recommendation for MAT, so unicompartmental pain in the presence of total meniscectomy, concomitant procedure of revision, and concomitant procedure with cartilage treatment or osteotomy. So this is my indication. And this is a case where I did ACL plus MAT in a 23 years old male soccer player, professional level. And you can see that at 12 months, you can see the meniscus is there and the ACL is there. This was a revision probably. And in fact, you have a nice signal. And as I say, more and more, I found multiple procedures that should be combined. And where I have to do meniscus, revision ACL or ACL, and osteotomy to correct some cases that you want to avoid, or revision ACL, or you have to avoid the destroy of your implant regarding the meniscus related to maintaining of malalignment. And in fact, the multiple procedure combination, so where you combine ACL, revision, osteotomy, and some scaffold or some even cartilage treatment. So this is a group of patients that we evaluate. And we have a group of patients, 43 patients, that they have Kergren-Lawrence 3. Mean age is a little bit higher, 40 years. Combined treatment, the HTO, contra scaffold, meniscal scaffold, and no failure and good results, and inpatient eligible for UK. And you can see that the more that you do, the better they are. So that means that you don't have to be afraid to go to do some complicated surgery, because at the end you get the results. And this is biological knee reconstruction, where we combine meniscus allograft transplantation, where we combine with ACL, then we combine with revision. You see, this is a group of patients that we have 20 MAT plus ACL primary, then we have MAT plus revision 18, and MAT plus ACL plus ATO 8 cases. But you see that 5 years follow-up, the results are not so bad, and definitely the patient do fine. And this I do some cases. This is just to show 47 years old, male, 15 years before he has an ACL reconstruction to medial meniscectomy, and he have a progressive varus, malalignment, pain, ACL instability. So what I did a CMI, you see, inside the medial side of the knee, because he has a medial compartment that was already a little bit bad. Then I did an osteotomy, and then I did ACL revision, say, in this case. And this is a case where you can see the CMI. This was the first, before the OR, and after the OR, you can see how it's opening the lateral part of the knee, how it is open. So we do the meniscus CMI. The fragile of this device is the weakness of this device, because it's difficult to try to preserve as much as you can during the OR. But I just did yesterday a revision on a patient that I did more than 6 months ago, the CMI, and it was really nice. But at the end, the results are good. And this is another case where I did 3 months X-ray. It was a 42 years female, ACL reconstruction and medial meniscus 24 years before, and he has progressive instability, varus knee, medial pain. So what I did medial MAT, valgus ATO, and ACL revision. And in this case, he sent me this beautiful picture of movie 1 year after, that he was able to return to ski after 1 year. And he's still very happy, and she's still going to be the master of ski. So you can reach this type of results, but if you have, you need to have a good indication. So my take-home message for this type of patient is a single indication are stronger if you do together. So MAT and scaffold as a bridging procedure in mild OA, but you should think to do a biological combined reconstruction to have a good outcome. And don't forget that when you go to metal, you cannot go back. And so we need to try to delay as much as possible this type of procedure where you just put metal. And I will go more for biological reconstruction as much as I can. I have done some cases where I build ACL plus uni-knee, but this is very cases where my biological reconstruction couldn't work because the erosion of the cartilage on the medial side and on the bone on the medial side is too much. And in this case, I propose if you have an instability with combination with medial destroying, I try to combine ACL plus uni-knee, but just in this case. For me, it's better to go for biological reconstruction. Again, thank you very much.
Thank you, Stefano, for a wonderful talk. And I think we are open for discussion now. Sanjay, or anyone wants to ask question to Dr. Stefano? Stefano, let me start the question answer session. You must be treating a lot of football players, and all football players have an inbuilt virus.
Yes.
And if one of them lines up with ACL tear, will you offer him alignment correction surgery for a football player along with ACL, or you do simple ACL with same alignment?
If the patient is an elite player and has a double varus, so both knee are varus, I leave it and I just do my ACL technique. If the patient is very much unstable and maybe is not playing elite soccer, I propose for the sake of his knee and for the sake of his reconstruction, both in combination.
Second question was related to CMI. Even I have an experience of using CMI once. The fragility of CMI is so, it's a very fragile thing. So when you take that posterior stitch with the help of your all inside technique, sometimes it cuts out. So is there any special trick to take that posterior stitch whenever you are taking the artificial meniscus?
The posterior stitch is very tough because sometimes, especially when you go back with the needle of the stitches, the CMI can come with you, no?
Yes.
Yes. So in this case, I normally have an assistant where I put the probe to maintain the CMI in position. And then I can remove my needle. But it's tricky. It's not easy. Definitely, it's not an easy procedure. That's why ActiFit, that is much more easy to implant, it will have increased popularity. But I think from the clinical point of view, the CMI is better than the ActiFit. Because CMI, at least it cannot hurt because it's really connective tissue. And what it can do, it can absorb itself, but without having putting any fragment or any loose body in the joint, how it does the action.
Okay.
CMI and scaffold are same?
CMI?
And scaffold is the same thing?
Yes.
Yes. It's a meniscus scaffold, artificial meniscus
Roshan,
scaffold.
is it available in India?
No, it's not available.
I
We
don't
got
think.
it for the live surgery during Arthroscopy Academy. So
Yeah, but
we
it's
are
a
leftovers.
Striker company has it.
Yeah.
Which company?
Striker has taken over now, but it's not available in India. Currently, it's not available in India.
Okay.
Yeah, we had a lot of trouble while operating. Many times very difficult to hold. And what I learned from Dr. Brian Cole is he takes an posteromedial portal and keeps a stitch behind with the help of knot pusher.
Yeah.
So
but then if you push too much, even in the posterior horn,
you
do the posteromedial and you tie too much, you can broken again.
Yes.
So it's very tough.
Very tough. Very tough.
Better to go with the assistant that to use the same portal. You put the probe and you just go slowly to remove the needle, and then you can do it.
Stefano, I had a question. In your meniscus allograft transfers, do you think that a bony plug is necessary or the soft tissue meniscus fixations are good enough? the ones which don't have a bony plug?
For me, the bony fixation is too much difficult, and also is not forgiving for the insertion. Because if you have to put the insertion in the right spot, and sometimes even if you do the measurement and so on, the sizing is a real issue on the meniscus transplant. And especially when you go and put the suture to your meniscus and tie the suture, then you have too much stress on some part of this meniscus, and you can have some broken of your meniscus in relation to the stress that you put in your suturing. And so the soft tissue fixation is much more forgiving for this.
Okay.
Maybe you have a not really very good hoop stress of the circular area, but at least you have to think that you are doing a sort of adjustment. You cannot be perfect. You are not perfect at all. Still.
Anybody has question before we start the case discussion by Dr. Mukesh? Mukesh, are you ready with the case discussion?
Rajkumar, do you want to ask a question? Raj, nothing?
Yeah, so I think Mukesh, you can start the case discussion.
I have one.
Yeah, Roshan, I will do one.
Yes. Okay.
Am I visible?
Yes, please
Yes.
go ahead, Mukesh. Yes.
So what I'll do, I'll present with some history and some investigation, and then
This is an open forum, so anybody can come in at any point. So please don't hesitate.
So she is a 31-year-old software engineer, female, weekend badminton player, not much. She had a history of fall 11 years ago, and she had sustained some injury to her right knee. For that, she had arthroscopic meniscectomy in 2010, and she doesn't know anything about the ACL status at that time, what happened to it. She was all right through the last 10 years, except some few episodes of instability in between. But she landed to me with pain and instability after a jerk for about 1 month back. So clinically, there was some lateral joint line tenderness. Medial was also there, but not as much. Latchman and anterior drawer was definitely positive. Pivot shift was grade 2 to 2 mostly, not 3 also. Mediolaterally, it was stable. Posterior drawer was negative. Alignment looks normal. So this is her MRI and limb alignment X-rays, which looks normal. So Stefano, would you like to read the MRI?
Yes, I saw the MRI is ACL rupture with medial meniscectomy performed 10 years ago. And you have a little bit of flattening of the medial medial joint, and you have almost a complete absence of the posterior horn of the medial side with a little bit of bone bruise of the posterior part of the femoral condyle. So for me, this should be a perfect indication, since the alignment is good, to do ACL plus meniscus transplant.
Okay. Anyone wants to add anything here?
Pardon, what he is going to do?
He is going to do ACL reconstruction with meniscus transplant.
Okay.
Anyone wants to add anything?
The patella looks good.
Meniscus transplant is not available in India. Now what to do?
So what I'll do now, I'll just show you.
I would put an insert on the foot to avoid and to check and to decrease the deterioration of the medial side, and to have decreased varus deformity, because this is 34.
31 years. So you will add HTO here?
So maybe in the future, maybe when it's 45, you will need an osteotomy.
So right
but
now,
would you do a meniscus transplant if the patient doesn't have a post meniscus syndrome? No pain, nothing. Would you still do a meniscus transplant? And here I can see quite a large scar of the meniscus still present.
So
it's like a partial meniscectomy.
So if he has no pain, I would wait.
Yes.
She had some pain. Definitely she came with pain and instability.
and is 40 years old, I would wait. Depends if he's 18 years old and he has already from when he was 11, the meniscus removed, I would suggest to do it.
So you will do it when patient is younger or
Yes,
little
when
bit
he's
old?
younger.
Younger.
Yes.
So I think her age currently is 31.
Yeah.
Yeah. So her current age is 31. At this stage, will you offer the meniscus transplant if it is available?
For me, yes.
For you, yes. For any of the Indian faculties agree with meniscus transplant, or they will do a simple ACL reconstruction?
We personally don't have any experience of meniscus transplant due to
But
non-availability.
if you do a meniscus transplant in this patient, he will have a restoration of all the joint because you have ACL and you have his menisci back in position. So you can give to this joint much more life than if you just do the ACL reconstruction. If you have available.
Yeah.
Mukesh, I have a question. What is the instability? What is the instability here? Grade 2, grade 3?
Grade 2 pivot.
Huh?
Attachment grade 3.
Okay.
And lateral joint line tenderness. Medial joint line tenderness was also there, but she was complaining more of lateral tenderness.
And what about sagittal alignment? Slope?
Sagittal alignment was good because I have not put here, but the slope was good.
Slope was normal. Okay.
Yeah.
So with normal posterior slope with the grade 2 pivot shift.
Yeah.
And with partial meniscectomy done 11 years back.
Yeah.
Okay.
Anyone here for HTO?
Not now.
High tibial osteotomy. At least I will not do it now because alignment is absolutely normal.
Okay.
Here I can't see any virus.
When you become a virus,
Stefano,
you will need it.
Stefano, do you add extraarticular tenodesis in this patient? Because the pivot is 2+.
Stefano, would you add lateral plasty here?
Yes. Yes.
Now,
what I'll do, I'll just go through the two diagnostic video and then see if anyone wants to change some plan.
Okay.
So that's the meniscus tissue, which is still present, some tissue over there posteriorly, but a significant amount of medial femoral condyle grade 3 to grade 4 cartilage loss, which is clearly visible, almost complete weight bearing femoral condyle. The anteromedial femur looks to be okay. But as you palpate almost grade 3 to grade 4, even some condyle changes can be seen on the posteromedial tibial part. But rest of the cartilage here looks, as well as some cartilage damage on the anterior horn of the medial meniscus. Lateral compartment looks okay. As I see, the lateral femoral condyle is fine.
Lateral side is good.
It's precise. The lateral meniscus looks okay. Lateral tibial plateau looks good. But there are some cartilage issues at the lateral tibial spine, as you see there. But the lateral compartment per se overall looks okay with that popliteus tendon and the medial and lateral and tibial plateau and lateral femoral condyle. Again, just one important finding which I got here, other than this big cartilage injury on the medial femoral condyle, as I moved my scope, there was a huge osteophyte on the lateral wall of the medial lateral femoral condyle, as well as there was a huge osteophyte on the roof.
In this case, you would do notchplasty or you leave it in?
That's what I just coming. Let me finish this. So huge amount of osteophyte was seen in the lateral wall as well as roof, as well as covering the PCL. So my question is, what the plan change after having this picture?
Mukesh, two things. One is, did you have a single leg standing HK, hip knee ankle X-ray? The reason I ask you this is that looking at your lateral compartment, you almost have a drive-through sign. You can actually pass your scope to your popliteus tendon quite easily.
Most of the times we do that. We get in most of our patients without any lateral instability.
And second aspect, Mukesh, is very important here, is how you had done your alignment X-ray. If you do it in external rotation, neutral rotation, and internal rotation of the leg. Because
if you see the patella was in the center.
Yeah, if you do the alignment X-rays, the long leg X-ray in the external rotation, you might get excessive valgus at the knee joint. If you do it in neutral rotation, still you can get a neutral alignment, but still it can be in valgus. So
But
you can
what the common saying is the patella should be in the center.
So usually people like it to be done in internal rotation so that you can get a better alignment. And that too, I totally agree with Vikram. A single leg standing X-ray will be more crucial here.
Okay.
In decision making.
This was both knee standing scanogram, and the single leg X-ray is not there, which we do routine AP.
Okay.
Which was not showing, I may say, grade 1, which is difficult to predict on X-ray. Second thing, what I want to do, everyone do tunnel view routinely to assess this notch issues.
Never. If I have to do my technique, I would do without making a notch.
No.
But if I have to do the femoral tunnel, I would like to do a little bit of light notch plastic.
Yes, yes.
Little bit means.
He's talking about notch plasty. You want to know about tunnel view. Okay. So not notch plasty. Obviously, even I will like to do notch plasty when I have to do an ACL reconstruction, because there are a lot of marginal osteophytes on the femoral as well as the tibial side. The tibial side, you can see the ACL attachment. There is osteophyte there on ACL attachment.
Yeah, there is
ACL footprint. So I think this is going towards more of a degenerative osteoarthrosis following failed ACL, non-operated ACL.
Yeah.
Yeah.
So now only ACL reconstruction at present, or would anyone still add HTO at this stage?
I think with the neutral alignment, there is no.
That's what I'm asking. So
Yeah.
it's only the issue of ALCA, joint line
Yeah.
congruency, only cartilage damage. Stefano?
Here, Mukesh, even the gait examination, the walking gait examination will play a lot of role, because sometimes you can get
sometimes
miss.
you can have a sort of maybe a sort of
thrust.
Varus thread is quite obvious. You can't miss that.
Related maybe to some laxity, and if this is the case, I could propose even the osteotomy. But maybe in this case, I would probably just put an insole on the foot.
You'll just put?
An orthosis on the foot to increase the valgus.
Okay. Anyone in, we don't have any scaffold or anything now. So on
For me, it will be a straightforward high tibial osteotomy. In fact, after seeing Stefano last year, we started doing close wedge osteotomies for ACL deficient knee. So
here with ACL reconstruction close wedge?
Yes. With ACL reconstruction close wedge.
Okay.
You do closing wedge or opening wedge?
Closing wedge. I will be performing closing wedge rather than opening wedge.
Anyone else here for HTO in this case?
Dr. Roshan and Dr. Stefano, would you think of correcting the slope and not doing an ACL with it? A slope correcting with a valgizing osteotomy.
He said slope is normal, posterior slope. If it is a normal posterior slope, I'm not bothered about the slope correction here. I'm bothered about more of joint preservation, which will happen because of valgus force realignment.
Yeah, the ACL should be done here for sure. So then you have to discuss about osteotomy. Yes. If you think that this is 31 years old and he has,
but you know, Mukesh, osteotomy is a pre-op decision. I think you know, if I am not discussed with the patient, I will not proceed with the osteotomy here.
That is why all my clinical findings were not going in favor of Varus.
So
and even the HK angle was normal. So I never told patient about HTO at all.
If you are not told, you should not do it. Then do a just notch plasty. Okay. And maybe you can convince the patient for osteotomy later along with ACL.
But if you believe all my findings that patient don't have a thrust, the X-rays were normal except grade 1 on the X-ray. What second plan without HTO?
But still, you have to take a consent from the patient. See, without patient consent, if you do osteotomy.
No. I'm not talking of osteotomy, Roshan, now. I'm telling patient don't have clinically varus.
Yeah, you can do it.
X-ray was saying no varus. Alignment is normal. So should we do only HTO, or should we add only cartilage procedure, or should we do both HTO with
See here, as Vikram has pointed out, your lateral joint opening is far better than your medial joint opening.
Agreed.
That means there is an element of arthritis on the medial joint, medial tibiofemoral joint.
Only because of joint? Yeah, Kalpesh.
I differ, Roshan. Sometimes you have a normal lateral opening, or if you look in the opposite,
You also know, yeah,
that could be same actually. So
most of the time you get this kind of lateral opening.
Yes.
But excuse me, why you want to treat cartilage on this patient that has a grade 2 cartilage lesion? That means
is it a grade 2?
Not even
because on palpating, it was almost, I was feeling the subchondral bone.
It's not reaching the subchondral bone. So for me, this means nothing.
You see, there is almost near full thickness cartilage loss again in the video, Stefano.
I don't think the subchondral bone is exposed here.
I know.
Mukesh,
yeah.
Can I ask you, what was the degree of instability, functional disability of this patient? Was it an instability because she's 31?
Yeah.
She has gone through that ACL deficiency for 10 years. The reason for a degeneration is probably the meniscectomy.
Agreed.
And if she is not very unstable, what is the purpose now of doing an ACL?
No, sir.
Are you trying to give her?
No,
that is what. Was she unstable for 10 years,
yeah,
or she became unstable now?
She told me from her history point, she had few episodes of instability in 10 years. But since last few months, she had some jerk, and then she had frequent episode of instability and pain.
So probably at this point, my thing would be to do an ACL with an extra articular.
Okay, nothing for cartilage?
Nothing for the cartilage.
Mukesh, what is the status of lateral collaterals?
Clinically, both lateral side was normal. Both sides were opening normally on both the lateral sides.
Oh, lateral, joint orientation angle?
Lateral, I'm not getting you. Lateral joint orientation angle?
Joint orientation angle.
What is that?
No, it is between the femoral condyle line and the tibial condyle line.
You are talking about JLCA, joint line congruence angle. Actually, I have not measured it.
Maybe because of the collaterals might be damaged. That may be the reason having the varus.
Okay. So, but clinically, there was no varus thrust or anything. Yes, Kalpesh.
Yeah, Mukesh, in such chronic cases with ACL deficiency, I would basically treat the symptoms. Now, the major symptom is instability and not the pain. Then only I think it's advisable to go for ACL reconstruction. If pain is a predominant symptom, I don't think ACL should carry any value actually in such situations.
She had, as I told you, she came with both, but instability and pain both.
Yeah, so we have to discuss very bluntly to the patient that this procedure may not reduce the pain. Sometimes we have observed that in chronic such situation after ACL reconstruction, there might be increase in pain also.
And Mukesh, you also said that the lateral side had a lot more pain than the medial side.
The offset of this.
Clinically, it was there, but didn't found any reason for that lateral pain.
No, but if you think, I mean, that itself will be a contraindication for me to do an osteotomy, because if I'm going to transfer the weight there, am I not going to over-constrain it?
Agreed. That was the point in my mind. So I just did lateral wall plasty and roof plasty and did single bundle anatomical ACL. My point here is, should I add something for cartilage now, like ACI or something?
No.
Because this patient, a relative of a pulmonologist, the pulmonologist was in the theater with me and was asking me, Doc, what's the status of cartilage now? You say it's almost grade 3. So what's the future of her knee cartilage?
When you have restored the kinematic and the ACL stability, you will have improvement of the knee pain.
Okay.
And if there remains the knee pain, you should do for meniscus transplant.
So I was not in the position to answer the doctor in the theater itself. So I just took out the biopsy and sent it for ACI, and I told that I'll discuss with the seniors and I'll let you know.
Okay.
So is there any role of doing ACI in such case?
In such case, the ACI is too big the area. The area to be covered by ACI is too big.
Mukesh, Mukesh, seriously no.
Seriously no, sir?
Seriously no.
Okay,
No,
okay.
don't even attempt.
Okay, okay, fine. Because I have told patient, I'll let you know. I did this case some 1 or 2 weeks back only. So I told patient, let me discuss some complex issue is there, intra finding. So I'll get the opinion of the colleagues and I'll let you know whether we need to do anything to cartilage or not. So just leave it, is the opinion of the house. For that reason, I presented this case.
Do you have any
Dr. Stefano, Dr. Stefano, in this patient, lateral plasty, biomechanically, is it unloads the medial compartment in this case?
No, here they have no problem on the medial, on the lateral compartment. This is a little bit of sort of impingement in this case.
Now I didn't do anything. Now if after 6 months patient again comes with pain, what would be the line of treatment to her now?
If he has pain on the medial side,
yeah.
If he has pain on the medial side,
don't have the meniscal transplant or scaffold here in India. So my
think
request to all colleagues, what to move ahead.
you have not available any meniscus transplant or scaffold in India.
No, we don't have.
No, we don't have it. Their regulation doesn't allow.
So I would evaluate the cartilage with the new MRI.
Okay.
And see if there is a sort of bone edema below the cartilage. Maybe I could do something on the cartilage, some ACI.
Mukesh, if your patient had an instability, and that is why you've done a surgery, I think this patient will be very fine after your ACL reconstruction.
Yes, for me, yes, I agree with you.
Yeah.
And the only thing that needs to be done should be the meniscus transplant.
Meniscus. So, and if this patient had a pain because of the meniscus and early degenerative OA, even if you do ACL reconstruct, this is not going to be the final destination, final answer. I think we have many things to think upon here. You know.
Yeah. Discussing as we discussed before, this for me is the perfect indication for ACL plus meniscus transplant. So for me, putting the meniscus in this case is mandatory, because otherwise you have an increased laxity even if you do your ACL of more than 2 millimeters. And this at the end will increase the rotational pattern of laxity, and at the end maybe you can have a failure in 5 years.
I think we should jump on to the next case. Samir, can you connect your laptop, Samir?
Okay, here any ramp lesion? I've seen any.
Samir, can you connect your laptop,
No, there is
Samir?
no ramp. That's a scarred meniscal tissue.
Yeah. So I think that was a very good case. And the message here is sometimes you can get a confusing, but I totally agree with Vikram. The one leg standing X-ray is more crucial here. And plus examination of the gait. Sometimes you can miss the alignment, but examination of the gait from behind will give you a complete idea about malalignment of the limb.
Very good.
That is, yeah. Samir, can you connect your laptop, Samir?
Maybe you can repeat scanogram, Roshan.
Yeah, maybe you can repeat a scanogram, because internal rotation. There is a wonderful study by Dr. Sachin Tapasvi from Pune, where he has done the scanogram in internal rotation, scanogram in external rotation, and scanogram on neutral position. And he found out that the scanogram done in external rotation gives a completely different picture than the scanogram which is done in a internal rotation of the foot. So that is a very important study which was done from Pune by Dr. Sachin Tapasvi, one of our colleagues from Pune, Stefano.
Okay.
Yeah, Samir.
Mukesh needs to unshare it, I think.
No, I have already removed him. I have. So
I
you
share my screen.
Okay. Yes,
Yeah,
Samir. Yes. You can go ahead, Samir.
Yeah.
We have last 10 minutes now.
Yeah, like this is the case today, 2 hours before I operated.
Make it PP full screen. Yes.
Yeah. This was the very interesting case which I got it today itself. So I got operated today just 2 hours before. So it was the patient presented to me with 30 years old, trauma 3 months back. He was treated, conservatively treated outside. Range of motion was painful on flexion as well as extension. There was no instability and patient has difficulty in walking. So I had these MRI pictures with him. On MRI pictures, you can see some bony piece you can see on the sagittal view over there. PCL is intact and some signal changes you can see on the ACL on the femur on the ACL side bus. And again, these are the MRIs which are available with me, MRI films. Again, you can see here in this
is there any lateral laxity, Samir? Clinical lateral laxity?
No lateral laxity is there.
Okay.
No lateral laxity was there. You can see just on this sagittal views, one bony piece you can see it there.
Yes.
PCL
There is a big bony piece.
Bony ACL avulsion from
It is
femur.
avulsion of ACL. ACL avulsion.
Avulsion of ACL.
Bony avulsion.
ACL avulsion and partial tear of the PCL also because of tibia has gone back.
Yes, exactly.
PCL, no.
Fragment of PCL.
PCL here, if you see, sir, PCL looks intact.
No. Tibia has gone back. If you see the tibial posterior border, it's completely gone back. Might be a PCL partial tear.
What is the clinical examination?
Bony fragment.
Okay.
And
patient was treated conservatively for 3 months, and now he presented to me 2 days back.
Okay.
And even these MRI films I'm having. This is the third MRI film. What you can see, we are having. Even you can see a bony piece over there. So, as you all said, I was suspecting like it's a bony avulsion piece from the. It doesn't look like from the ACL.
Meniscus root, bony avulsion.
Yeah. So when we went inside, it was the picture bony avulsion. You can see it here.
Bony avulsion. But the ACL looks that it has been elevated completely. It's like a injury of a child, it seems.
Okay. Yeah.
Arthroscopic picture. I saw this was the bony avulsion.
Yeah, but
this is yes, this is three-month-old injury, right?
3 months old injury.
Yeah. The touch is a touch on top the ACL.
So now what to do? What do you think?
If you want, you can try to reinsert. If it's working, you can try to reinsert with 1 or 2 screws this fragment.
Okay, but do you think it is more posterior compared to the ACL avulsion?
No, it should be put on this position where there are some scar tissue inside. You should put more anteriorly.
You can do little bit of debridement anteriorly, remove that scar tissue.
Debride this part anteriorly.
Initially, when I started scoping, I thought the same thing what you are discussing. Then as I went forward, like as I started doing the scoping, I mobilized the fragment. And then I came to know that this bony piece has been avulsed from along with the root of the lateral meniscus as well as root of the medial meniscus.
Oh, shit.
And the PCL is intact. PCL is intact posteriorly. You can see PCL was intact there. And it has been avulsed piece of medial meniscal root. You can see it now here, medial meniscus. And on the left lateral side, you can see there is a lateral root also. So as such, if you see, now what to do for this? Like if you see here, there is no ACL intact.
No, no ACL.
No ACL. This has been attached from the lateral meniscal root as well as from the medial meniscal root. Now you need to fix this bony piece as well as you need to reconstruct the ACL.
Could the patient extend the knee completely? Was there any impingement?
Patient can't extend. He is having range of movement painful. But here,
What is the range of movement? What was the range of movement?
Is there any complete ACL injury, Samir? The ACL is completely gone?
Yeah, ACL is gone. Some few fibers were left when I saw. Some few fibers were left.
Okay.
But almost nothing was there. You can see the real picture here. Intro. So now how to fix this?
You can't.
Samir, I operated this type of cases, few cases. This is a vital fragment. You can't remove it. So what it is, I've taken out the entire the bed and mobilized the fragment onto the bed, and then I have taken the ACL graft, ACL jig. Then I put the K wires into the fragment, and then bent inside and pulled back, and then kept it for 3 months. After that, I removed the K wires, and then I gone for the ACL reconstruction. Because
you can use
putting a screw. Yeah, putting screw is very difficult.
In this,
as when you are going to remove, do the ACL, just you can give the nick at the distal part, and you can unbend it and remove the K wires.
And what about ACL?
Yeah, ACL after 4 or 5 months you can do ACL instead of removing.
Because if you see this case in last 20 years now, I have seen for the first time such a case. Like both medial root as well as lateral root was involved, along with the bony fragment was there, and ACL was not there. Anybody
but
has
if the patient if the patient does not have instability, why should you do an ACL reconstruction? Can't you treat it conservatively?
Okay, what you say is right, but see, there is a picture. What you can see it here, right? Patient is not able to tell you anything. He had a trauma and now he started getting this pain.
Okay. No, that's why I was asking you, what is the range of motion?
Because of this
But I will tell you, Samir, that is one thing which is surprising is in spite of having both the posterior, medial and lateral root, there is no meniscus extrusion on your MRI. That means this root avulsion, this root avulsion is clinically not very significant. It is just a bony contusion which has got extended up to the root attachment, probably in my viewpoint. Yeah,
that might be the reason.
And just removal of this bone piece, because the union of this bone piece is very, very unlike, since it is more than 3 months. So what I will do is I will try to remove the bone piece and keep the try to preserve both the root attachment posteriorly and excise it completely.
Samir,
You want to excise the piece?
Not now, because patient doesn't have instability. Does patient has instability?
Patient doesn't do any symptom. Now 3 months before he had fall. After that, he has been treated conservatively for this bony piece segment. He came to me saying that, sir, मुझे बहुत ज़्यादा pain है. Do something for me. I am unable to walk, and there is difficulty in
Stefano, do you have any experience of these root avulsions, traumatic bony root avulsions?
From not like this, because
not like this.
Is a very special one. Yeah. But I would probably agree with you that probably this fragment is already gone. So I would remove it, and I would like to fix the root and do the ACL at the same time.
Yes.
Because you can put the tunnel over there without any.
Yes, Kalpesh.
Samir, I have experience of a similar case, but in that case, only the lateral meniscus was attached, the root was attached with the bony fragment. So what I did actually, that the anterior part of this intercondylar fragment was absolutely non-essential, and it was blocking the extension. So I removed it partially, and then I used that suture tapes through the root, and it was incorporated in the ACL tunnel. So it really compressed the fragment, whatever remaining fragment was there. That's what I did in that case.
Yes.
Okay.
there's an interesting paper from PGI by Dr. Mandeep Dillon on neglected ACL avulsions, in which they have, even after about 2-3 years, they have debrided the fragment and fixed it back to the bone. So do you think still removing this fragment, if we do adequate debridement, is a solution?
No, I think now this bone, as Roshan said, like he wants to excise the piece and do a medial meniscus root repair. Again, other lateral meniscus as well as medial meniscus root repair he wants to do, right? And then ACL reconstruction in another stage if he had instability, Roshan?
Yeah, because you told me that there is no instability for this patient.
Yeah, he doesn't tell you now because at present
No,
he's having...
clinically on examination, does he have any instability?
No, clinically he's not allowing us fully.
No, like, but during now you are operating na?
Under EUA.
Under examination.
Typically now while operating we get ACL anterior draws, you get even Latchman, you get.
Then obviously I will do a root repair like what Kalpesh has told. Root repair on medial lateral, provided I am able to preserve both the roots. I am very sure I will be able to preserve both the root because this looks like a bony avulsion, and do an ACL reconstruction after removal of the excising this piece.
Why won't this fragment heal? Because it's only 3 months old and it's a complete cancellous bone, and there is still some bone left.
Once there is a rounding of the edges, unlikely this bone will.
You can see the cancellous bone on the undersurface of the fragment also.
Samir, is there any cartilage area in that fragment? Cartilage on medial tibial condyle cartilage area is there in that fragment?
Doesn't look like.
When we go ahead, we will see that there is no, it's dead in the center.
Yeah, it is a lateral tibial condyle, tibial eminence fracture. It's not a cut. It doesn't look like cut.
It looks like
it's
that.
More posterior. It's touching the PCL. Almost you are touching the PCL. I have created posteromedial and posterolateral portal. I have seen from behind also. PCL is fully intact. Now you can see when I am probing it, PCL is, you are looking that is PCL. And surprisingly, PCL is not avulsed.
Limit of this fragment.
Yeah, I could suspect that this is an intercondylar fracture of the tibial eminence, and this could be a ACL deficient knee from beginning actually.
Yeah, right. That might be the original scenario. So what I did in this piece was, as you people said, I tried to save this piece. So this was the posterior root of the lateral meniscus, which was there along with that piece. Even root of the medial meniscus was there along with this, and PCL was also intact. So I made a fair debridement or the burying over the attachment of the PCL root, medial meniscal root as well as lateral meniscal root before going for the preparation of the bone bed for the bed. And then I fixed this bony fragment with the help of the guide wire. You can see this. I have fixed this piece with a guide wire, and then through this I will do a suture bridge, I thought initially, and I passed and I fixed this bony piece and I kept it upright. After fixing this bony piece, the main challenge for me was to create a tibial tunnel which has to be anatomical.
ACL.
After that, what I did was I slightly burrowed out this bony piece which was there, a bit like for 1 mm or 2 mm, so that my tunnel, it should be just in line with the posterior border of the anterior horn of the lateral meniscus. So for that, again, what I did was I fixed temporarily with the guide wire. After fixing temporarily with the guide wire, we created a tibial tunnel of 8 mm by burying slightly the bony piece which was there. And now the bony piece, lateral meniscal root as well as the medial meniscal root are in place. We checked it, and you can see the even the fracture line when we fixed it, it came into contour properly. And after that, we did a tightrope fixation for the ACL. And here we railroad the sutures, material. And as the Kalpesh said, these sutures, after passing through this drill bit and this piece, we took it from this ACL tunnel itself, because there was no place for me to do another tunnel and to bring out the sutures. And I kept the drill bit up till end until I fixed my ACL completely by doing the suture.
Samir, your initial video didn't show this big cartilage lesion extending on the medial tibiofemoral joint.
Pardon?
Your initial picture didn't show this.
Yeah, I'll show you after this we'll go. Right? After this we'll go. Because this is the editing just hardly 15-20 minutes before I have done now.
Okay.
Then I tried like where it becomes easier for me. And then I passed the graft from this. And I fixed this ACL graft as well as outside. I fixed it over with bio screw for the ACL and even here. Then we tried for the fixation how it is, and you can see now we have restored the ACL root, medial meniscal root as well as lateral meniscal root. We probed it and saw. So after doing this, I thought I should share this case with you, like what will be the fate of this case. Even I don't know.
Yeah, I think there is a high chance of that fiber wire getting cut through with that fragment, because already it has gone little.
But see, on table there was nothing else with me, so I thought this is the best what I can do.
Yeah. Agreed. But now, what about rehab now? Will be very slow.
Suture tape or fiber tape is a better option.
Because that bony piece has to be get healed. Because I have done a thorough burring over the tibial posterior surface, as well as I have burred over the root attachments on the lateral and medial side. And I have told the patient that he might need revision for that root repair if needed.
Good job, Samir. Good job. Very good.
Very good.
Very well executed.
Very tough.
Yes. Fantastic.
Congratulations to the surgeon.
Yeah, good job, Samir.
So, if we don't have any question, yes, Gaurav, you have a question before we end the session?
That was a rare one-off sort of case handled.
Yeah, it is a rare case.
Very rare thing. So that was really
Samir is always known for a rare case. He's a rare man. He's a rare breed.
Himself is a rare species.
He's a rare species.
So that was brilliant.
Found only in Mirage.
See, for lesser mortals like myself.
Found only in Mirage, so we can
only
start.
He operates rare cases.
Rare case.
Only.
So I think we must thank Dr.
It was by my chance. I thought like this. I don't know, because when I entered inside, I thought it will be a routine ACL avulsion fracture. I will fix with 2 screws and come out.
No, that was a wonderful case.
So that was very nicely done. I have just one thing to ask, boss.
Yes.
Yeah, Gaurav.
You know, whenever I have done these ACL, I've never seen something like you showed today, okay? But whenever I've done these ACL avulsions, I always shave inside the bed and I always shave that bony fragment. And sometimes, you know, the edges of the fragment, I will just refresh them with a punch. So with your fragment, I'm sure you would have done all this refreshing job. Were you not afraid of losing bone chunk? Because there seems to be a very small amount of bone there.
Yes, you are right. Because even when I debrided the bony bed and this chunk I debrided so that I want bony healing over there.
Yes.
So with a big chunk over there. Anything else you would have done other than this? Because when I went inside, when I saw, initially I thought I will take the bites from the posterior root itself with the help of the 45-degree passer. from the medial root as well as lateral root, and those sutures I'll bring it anteriorly and fix it over the suture anchor. But as I have to do a ACL repair along with this, only option left was this.
I think we had a wonderful session. This is almost 2 hours. I must thank Dr. Stefano for wonderful 2 talks. Especially your first talk was fantastic. It was mind blowing. It has cleared our lot of ideas and understanding about ACL. And this talk of yours is uploaded on YouTube. Our channel is Arthroscopy Academy. I must thank from the bottom of my heart Dr. Stefano for your wonderful explanation in detail and in-depth examination. We will keep you involved in many more sessions if your time allows. And big thanks from Indian fraternity.
Thank you very much. Thank you for my Indian friends. It's been a pleasure to be with all of you.
Yes, thank you.
Thank you very much for your time and to organize this. Very good. Ciao.
Ciao, ciao, ciao.
Ciao.
Ciao. So,
China.
Bye, everyone.
Yeah, I think we all should leave. It's already a live stream.
Hi, Roshan.
Amravati, abhi